A woman with Addison's disease, and she is crashing. Blood pressure 78/40. She is nauseated, weak, her skin has a strange bronze tint, and she has been craving salt for weeks. You have fluids running wide open, and the pressure is not budging. There is one drug this shock is waiting for. Do you know what it is? Here is your question. A client with known Addison's disease has a blood pressure of 78/40, nausea, weakness, a sodium of 128, a potassium of 5.9, and a glucose of 54. Fluids are running, but the pressure is not responding. Which action is the priority? A. Administer IV hydrocortisone. B. Give another liter of saline and start a vasopressor. C. Give insulin and glucose to treat the high potassium. D. Restrict sodium and fluids. Pause right now and commit. 3, 2, 1. The answer is A. IV hydrocortisone. This is an adrenal crisis, and its shock is different. It will not respond to fluids, and it will not respond to pressors until you replace the missing cortisol. Hydrocortisone is the one drug that turns the lights back on. Everything else you do around it. Here is why. In Addison's, the adrenal glands have failed, so there is no cortisol and no aldosterone. Without aldosterone, the body cannot hold on to salt or get rid of potassium, so the sodium falls and the potassium climbs. Without cortisol, the blood vessels lose their tone and stop responding to the signals that keep them squeezed. So the volume collapses, the pressure drops, and here is the cruel part. You can pour in fluids and hang a pressor and the vessels still will not answer. You are here in a shock that only cortisol can lift. It helps to see it against its mirror image. Addison's is too little cortisol. Low blood pressure, low sodium, high potassium, low glucose, bronze skin, and a craving for salt. And the fix is to give steroids. Cushing's is too much cortisol, and it is the exact opposite. High blood pressure, high sodium, low potassium, high glucose, a moon face, and purple striae. And there, the job is to taper the steroids down. Everything Addison's lacks, Cushing's has in excess. So here is the order of operations. First, steroids. IV hydrocortisone, immediately, because it is the one drug that reverses this shock. Second, fluids and sugar. Normal saline, with dextrose, because they are volume depleted and their glucose is low. Third, fix the rest. Watch and treat the potassium, and hunt down whatever triggered the crisis, usually an infection or a missed steroid dose. Here is the rule to carry out of this. In an adrenal crisis, when the pressure will not respond to fluids, give IV hydrocortisone first. It is the drug the shock is waiting for. Draw a cortisol level if you can, but never delay the steroid for the result. So how do you spot it? The shock that will not lift with fluids or pressors is the first clue. Then look at the pattern, because it runs backwards. A low sodium, a high potassium, a low glucose. Add bronze-tinted skin, a craving for salt, and a history of steroids recently stopped, or a body under stress. When the electrolytes go the wrong way, low sodium with a high potassium, and the pressure will not hold, think adrenals, and give the steroid. Keep the two treatments in their lanes, because this is the part that trips people up. Fluids and pressors fill the tank and try to squeeze it, and normally that is enough. But in an adrenal crisis, the vessels are deaf to them. They cannot respond, because cortisol is the hormone that lets them respond, and it is missing. Hydrocortisone is what makes the vessels listen again. So the pressors do not work until the cortisol is on board. That is why the steroid comes first. And here is how patients get here in the first place, because most adrenal crises are set up in advance. Chronic steroids quietly switch off the body's own adrenal glands. So there are two ways to tip such a patient over. 1. Stop the steroids cold. The suppressed adrenals cannot restart in time, and the body runs out of cortisol. 2. Hit them with a stress, an illness, or a surgery, without boosting the dose. Demand outstrips a supply that can no longer rise to meet it. So you taper slowly, you stress dose for illness, and you never stop steroids suddenly. 2. To lock in. For the picture, in Addison's, everything is low, except the potassium, sodium, low, blood pressure, low, glucose, low, potassium, high. And for the fix, steroids save, steroids first, saline with sugar, and then the potassium and the trigger. Low and bronze, with a high potassium, and a shock that will not lift. Reach for the hydrocortisone. Now the wrong answers. B. More fluids, and a pressor. It is the reflex for any shock, and it is exactly the trap here. Because these vessels will not respond until you give cortisol. You could chase that blood pressure all night and lose. C. Insulin and glucose for the potassium. The potassium of 5.9 is real, but it is not the killer in front of you, and the cortisol you give will help correct it anyway. And D. Restrict sodium and fluids. That is backwards. They are salt-wasted and volume-depleted. Restricting is the last thing they need. Tie it together. Your cues: a blood pressure of 78/40 that will not respond to fluids, a sodium of 128, a potassium of 5.9, a glucose of 54, and a history of Addison's. Your action: IV hydrocortisone now, with saline and dextrose alongside it, then treating the potassium and finding the trigger, and the outcomes you are steering toward: the pressure finally responds, the electrolytes correct, the glucose recovers, and the crisis is reversed. Now test yourself. Different patient, same shock. But this one has no history of Addison's, no bronze skin, and his potassium is normal, at 4.2. Here is the catch. He was on long-term prednisone and he stopped it cold 5 days ago. Emergency? Yes. Chronic steroids suppress the adrenals, and stopping them abruptly leaves the body unable to make its own cortisol. The potassium can be normal because aldosterone is preserved and there is no bronze skin. But the crisis and the fix are the same. One more. A known Addison's patient, calling from home. She is not in shock. Her pressure is 100/64. But she has been vomiting all day and cannot keep her steroid pills down. Do you just tell her to rest? No. She needs her steroid, now. Illness raises the body's demand for cortisol, and if she cannot absorb her pills, she is heading straight for a crisis. This is where sick day rules live. Increase the dose, and if she cannot keep it down, give it as an injection into the muscle. You prevent the crisis. You do not wait for it. One last patient, also in shock. Blood pressure 80/44. But look at the labs. The sodium is high, at 148, and the potassium is low, at 3.4. And there is a fever and a high white count. Do you reach for hydrocortisone here too? No. This is not an adrenal crisis. The electrolytes point the other way, and the fever and the white count point to sepsis. Not every low blood pressure is an adrenal problem. It is the backwards pattern, low sodium with a high potassium, that points to the adrenals. Here, you treat the infection. Next episode, temperature 105.8, heart rate 148. A patient who is agitated, confused, and burning up, with a history of thyroid disease. This is thyroid storm. The opposite emergency, a body running too hot. You have to cool it, block it, and calm it. But in what order? That is episode 6.